Should I embarrass people by having them move to the front? No, I'll leave you guys alone for today. So good morning. I'm really thrilled to introduce one of my really great friends, Dr. Ari Cedars. So Dr. Ari Cedars has actually been in Houston with us before. He actually did his medical school here at UT Houston and actually did really interesting research work with the famous Dr. Techmeyer across the street. And then my claim to fame is that I actually was a junior fellow under senior fellow, Dr. Ari Cedars, while we were at Washington University together. And we both fell in love with adult congenital heart disease at that point in time. So now he is on staff at UT Southwestern with their adult congenital heart program, and he's doing some really interesting, innovative work in looking at patient-centered outcomes research in adult congenital heart disease and really turning around the way we actually look at outcomes in adult congenital heart disease. But today, he's actually going to talk to us about durable mechanical support in adult congenital heart disease. Dr. Cedars.
All right, thank you, Huey, and thanks for that. Thanks for the introduction. This is actually another area of interest that I have, durable mechanical circulatory support, probably at least in part because my wife is a heart failure, heart transplant cardiologist, and so I heard about it all the time at home. And you know, all the cool toys for the general heart disease population, I try and see if we can use them in adult congenital heart disease as well. But I think there's actually a compelling story here, and I hope that by the end of the talk that you'll agree with me. I unfortunately don't have anything to disclose, although I am building my Sunshine profile. So my talk, the outline in broad strokes we'll start with a review of heart failure and adult congenital heart disease, move on to transplant and congenital heart disease, then on to mechanical circulatory support, what is and is not known, and then move on to something that's a little bit more aspirational, but that I think is going to be of great interest to me, which is the possibility of mechanical circulatory support, specifically ventricular support in Fontan palliated single ventricle patients. So I always start my lectures with this kind of like self-deprecating apologetic slide because I feel like, you know, we're kind of the bastard child of the adult cardiology field. No one really cares. Am I ever going to actually see a patient like this? And so I always have to kind of, in protests, demonstrate why you should care and why to me it's important and why it should be important to you too. So you'll have to bear with me through some slides that you probably have seen as a prelude to almost every adult congenital talk you've ever had. The adult congenital heart disease population in the United States as well as in Canada is growing. There's actually data from Canada. And you can see that since 2000, the numbers of adults with congenital heart disease indicated in red has exceeded the number of pediatric patients with congenital heart disease indicated in purple. And this goes both for congenital heart disease writ large, ASDs, all the way to single ventricle, as well as, which is in the top graph, as well as those with complex congenital heart disease, as depicted in the bottom graph. So why is it that there are so many more adults now than children with congenital heart disease? And the reason is because pediatric cardiologists and pediatric cardiac surgeons are doing a great job. This is data also from Canada, from Paul Carey and his group in Quebec. And you can see if you look on the left-hand side of this graph, which depicts age of death in the congenital heart disease population, which is indicated by the yellow bars, as compared to the general population of Quebec, which is indicated by the black line, that in the 1980s, most patients born with congenital heart disease were dying at a fairly early age, whereas within 2 decades, now the age of mortality in adult congenital heart disease, or in congenital heart disease, nearly matches that of the general population in Quebec. And so, why am I even talking, right? I mean, mission accomplished. They're doing just as well as the general population. Not quite. So this is data that's more recent. It's from the Netherlands. And you can see that although people with simple congenital heart disease, depicted in green, have a life expectancy that's quite similar to that of the general population in the Netherlands, that's depicted in black there. Those with moderate, indicated in blue, or severe, indicated in red, congenital heart disease actually have substantially shorter life expectancy. And in particular, those with severe congenital heart disease, their life expectancy can be like 30 years shorter median compared to the general population. What's more, they get hospitalized way more often than people without congenital heart disease. This is again data from Quebec, and you can see that those with non-severe congenital heart disease are admitted twice as frequently as the general population. And those with severe congenital heart disease, it's 3 times more common than in the general population. So what is a congenital heart disease patient that I see in clinic? What would they look like? So I have anecdotes throughout this talk, and so I think that they'll I hope that they're going to be illustrative of the types of patients that I'm seeing, give you a flavor of why I think that mechanical circulatory support is going to be important in this population. So this guy is a guy I saw my first year in practice, and he came into clinic, and he walked into clinic, and he just was one of the more bizarre looking individuals that I've ever seen. He wore these really loose pants, and he kind of walked with a little hobble, and I came to find out that he had one leg that looked for all the world like he had elephantiasis in it. And it's because he had been cathed so many times as a child that he had lymphatic disruption of that one right lower extremity. And so he had this one big elephantiasis leg, and the rest of his body was like normal size. Nevertheless, he was doing great. He was born with tricuspid atresia, had an old style atriopulmonary Fontan. He was working, he was 29 years old, he was feeling good, and then he met me, and everything went wrong. Within 2 or 3 months of meeting me, he was hospitalized with what we thought was just general heart failure. Turned out that he was having an atrial arrhythmia, and that led to him getting fluid overloaded. We treated him for his atrial arrhythmia, we diuresed him, he got better, we discharged him from the hospital. Within another month, he was back in the hospital again, this time with another bout of heart failure. We cathed him this time because he was not in the atrial arrhythmia. Found out that his his only ventricular filling pressures were elevated. His pulmonary vascular resistance was fine. He basically just had a stiff heart. Contractile function was normal. So we diuresed him, we increased the intensity of his diuretic, again discharged him. Within a month he was back again in heart failure, again fluid overloaded, and again with increased ventricular filling pressures on cath. But this time we found out that he had developed protein-losing enteropathy, and his albumin levels were low, and he was really struggling. We worked a long time to try and get him on a regimen that would keep him dry and out of the hospital. And this was a long hospitalization. He was in probably for, I'd say probably 2 weeks while we were trying to get his medical therapy optimized for him to hopefully do well as an outpatient. Now this patient, although it sounds like a catastrophe, is actually not that unusual in the adult congenital heart disease population, particularly among single ventricle patients. If you look at this graph, this is data from Germany, you can see that most congenital heart disease patients will develop heart failure at some point in their life, and the incidence of heart failure and congenital heart disease goes up as they grow and go through life. Those with a single ventricle obviously have the highest incidence of heart failure, and those with more complex lesions have a higher incidence of heart failure. But even those with simple lesions develop heart failure at some point. So not surprisingly, given the demographics that we've already talked about, the population is growing, the population is aging, so heart failure, incidence of heart failure hospitalizations in the United States is growing. This is data from the national inpatient sample that Sasha Opatowski came out with a few years ago. And you can see, well, not shown here is that heart failure is among the 3 most common admitting diagnoses among patients with congenital heart disease. And the incidence of heart failure hospitalization in the United States among patients with congenital heart disease has been growing over the past decade, year by year. Not only are they getting admitted with heart failure, but once they get admitted with heart failure, they're much more likely to be readmitted. In fact, when you have an admitting diagnosis of heart failure, it is more likely than any other admitting diagnosis among the congenital heart disease population that predisposes them or predicts a later readmission. And the most common diagnosis at the time of readmission in the adult congenital heart disease population is heart failure. And getting admitted with heart failure is a big liability for congenital heart disease patients. This is data from the Netherlands. You can see that once you've been admitted once with heart failure, you have a 20 to 25% chance, depending on if you're a male or a female, of being readmitted of dying within the next year. So it conveys a significant bad prognosis. Not surprisingly then, the most common reason for death in the adult congenital heart disease population is heart failure. This is data from the Netherlands, and this almost superimposable graph comes from Germany and shows that pretty much across the Western world, people with congenital heart disease are dying of heart failure. So what does a failing patient with congenital heart disease look like? Now, this is another patient that I saw in clinic. He was transferred to me from our affiliated pediatric hospital, and he had been born, again, also with tricuspid atresia. He had an extracardiac Fontan. He was 20 years old, 19 or 20 years old, I believe, at the time when I met him. And unfortunately for him, he had developed a viral cardiomyopathy when he was in his teenage years, and his EF had gone down to like 15%. And they had listed him for transplant. They thought, this is going to be it. This is his time for transplant. But remarkably, modern neurohumoral goal-directed medical therapy led to a significant recovery in his ejection fraction to around 30 to 35%. And he stabilized and did well and made it until adulthood. Now, they had an ICD in him and they were watching him carefully, but he was doing well. He was functioning in life. He was actually married at a young age. We can decide about whether or not getting married when you're 19 or 20 is a good idea, but he was. He was going to school to be a chemist. He was working to pay the bills at Red Lobster as a chef. And his pediatric cardiologist said to me, keep a close eye on him, because pediatric cardiologists, some of you may not realize this, but they don't trust adult cardiologists. So what they do is they browbeat you anytime they transfer one of their patients to you and say, I will hunt you down if this patient has a bad outcome. So I was scared because Huey knows who this particular pediatric cardiologist was, and he's kind of, he actually might hunt me down if something bad had happened. So the guy was actually doing great. He was working at Red Lobster, and he called me and told me, he developed a URI, and we saw him in clinic. He wasn't fluid overloaded. He was just kind of stuffy. And I said, you're probably fine, and we'll just kind of continue to keep an eye on you. And he went to work that night and had sudden death while he was at work at Red Lobster. And his defibrillator did not save him. He got bystander CPR. Remarkably, it was successful. He was in the hospital for then probably a couple of weeks in the intensive care unit. And once he got out of the intensive care unit and he was able to kind of converse with me, I said, you're getting listed for transplant and you're not leaving the hospital until you get a transplant. Because at this point, we didn't have any other alternative. No one was using VADs in congenital heart disease patients. They were just kind of nascent technology in patients with normal hearts. And so I actually kept this guy in the hospital for 6 months as a 1A exception, waiting to get him a new heart. And this depicts another aspect of congenital heart disease patients listed for transplant, which is they wait forever to get transplanted organs, because in particular the Fontan patients, they want it to be just right. They want it to be like a little oversized but not too oversized, because the PVR is always higher than you think it's going to be, and there are all these reasons they end up waiting for a long time to get transplanted. So, and I had the fear of God over this pediatric cardiologist coming to get me. So I just put him up in a corner room on one of the floors of our hospital, and he just set up camp there. I would only round on him twice a week, because he was in there playing video games, practicing guitar, reading his books. His wife was in there with him. His family would come visit. It was like their home, away from home. So he finally got an organ. We had a celebration. He had been admitted in the fall. This was in the late spring. And he had a rough post-operative course where he had he had a lot of hemorrhage in the OR. Although they had coiled his collaterals, you can never get all of them, the all unseen small collaterals. He came out of the operating room somewhat vasoplegic, which is not uncommon due to chronic hepatic congestion in Fontan patients. His kidneys weren't working. He got through, and his right ventricle was doing poorly, the graft organ, because the PVR is always kind of higher than you expect it's going to be in Fontan patients. And he stabilized, his hemodynamics stabilized. We go to wake him up and wean him from the ventilator, and he won't wean from the vent. He has profound respiratory muscle weakness, and it's because he had complete diaphragmatic paralysis. He had basically gotten both of his phrenic nerves bagged when he had the operation. Remarkably, he actually ended up, there's a happy ending to this story. He got a trach, he learned to breathe again using alternative respiratory muscles, and he did very, very well afterwards. Ended up, and I seen him, I didn't really see him in clinic anymore. He didn't have congenital heart disease anymore, but I would see him when he would go to see, the heart failure specialist, and he looked awesome. He was no longer blue. He was walking around. He had had a divorce, which I guess that tells you about getting married when you're 19. But he looked great. But he had a rough course, and this is not unusual in patients with congenital heart disease. And a lot of the reason why he had so much difficulty in his perioperative course was because he just had chronic end-organ congestion, which is characteristic of all patients with a Fontan circulation: chronic liver congestion, chronic kidney congestion, lungs that were not getting well offloaded and that had no pulsatile flow. So, transplant and congenital heart disease, it gets done. For years, people have said congenital heart disease patients, they don't do as well as the general population when they get transplants. And that's true. If you look at congenital heart disease writ large, the entire population is kind of a monolith. But if you separate out those patients who have a Fontan circulation, you can see that the reason why they don't seem to do as well, looking at, this is actually a meta-analysis, I should explain myself. Each of the listings is an article that's been published in the past where they looked at survival outcomes among transplant recipients with versus without congenital heart disease. The top group of dots are those with congenital heart disease in a Fontan circulation. The bottom group of dots are people with congenital heart disease without a Fontan circulation. The graphs that you're looking at from top to bottom are A, 30-day outcomes, B, 1-year outcomes, C, 5-year outcomes, and D, 10-year outcomes post-transplant. So you can see that 30-day outcomes after transplant in Fontan patients are substantially worse. And that's because of all of these perioperative complications that I was talking about. In addition to just the fact that the surgery is more difficult, they have, as a result of chronic end-organ congestion, lots of factors that predispose them to mortality in the perioperative period. However, as you can see, if you can get out of that perioperative period, by 1 year, outcomes are indistinguishable from the non-congenital heart disease population. And with 5 years and 10 years, this trend continues. And actually, longer term, congenital heart disease patients with transplant end up doing better than non-congenital heart disease, probably because they're younger. And this graph shows what specific outcomes patients with congenital heart disease after transplant may be more likely to experience. Again, each line is a prior comparison in this meta-analysis, and I'll walk you from top to bottom. Top is malignancy. Obviously, malignancy post-transplant much more common in the non-adult congenital disease population. Why? Because they're like 3 decades older. You get more cancer as you get older. B, primary graft dysfunction. That's just a reflection of the fact that the surgery is harder, the surgery is longer, it takes longer to get that old heart out and the new heart in. C is stroke. Again, probably perioperative, probably an indication of the difficulty of the surgical operation. I'm sorry, that's B. C is hemorrhage. Again, perioperative. That was B, C. D is hemorrhage. So C is actually primary graft dysfunction. Wait, no, I've gotten lost. C is stroke and D is primary graft dysfunction. E is infection. infection risk actually seems to be lower in congenital heart disease population. I don't really know why that would be. I guess the surgeons are more assiduous when they're taking care of somebody who's got congenital heart disease. F is rejection, which is remarkable to me, right? Because supposedly congenital heart disease patients are allosensitized out the wazoo. They've had a ton of exposure to blood products, and yet the incidence of long-term rejection doesn't appear to be substantially different from the general population. And then last, G, transplant vasculopathy, and it seems to be trending lower in the congenital heart disease population. The only thing I can attribute that to is, again, the fact that they're younger and they just may have fewer risk factors for atherosclerotic disease. And probably there's some combination of atherosclerotic predisposition with the inflammation of chronic rejection and this milieu of the transplanted organ that leads to transplant vasculopathy. But the upshot of all of this data is that patients with congenital heart disease do really well when they get transplanted. Even the most complex patients, even those with a single ventricle, if you can get them through the first perioperative period, they actually do really well. The key is, can we improve that perioperative period? The second key is, and this was something that we alluded to when we were talking about the blue patient at Red Lobster, is that they wait forever to get a transplant, and patients with congenital heart disease have a far higher risk of dying or delisting due to clinical worsening while waiting for transplant. So if you can actually get them to transplant, they do well. But getting them to transplant is not the easiest thing in the world. And this is actually data, and I'll walk you through this slide, this data using the SRTR database. And I'll start kind of backwards here. So going from the bottom, C, this is the entire congenital heart disease population who were listed for transplant versus the entire non-congenital heart disease population who are listed for transplant. And you can see that for the group as a whole, there's no difference in dying or delisting due to clinical worsening. However, if you separate them by listing status, and keep in mind that something like, I don't know exactly what the status is, but it's like 75% of patients who actually get a transplant nowadays are listed 1A when they get a transplant. The HeartFit or heart transplant people can confirm this for me, but it's something like that. Almost everybody is 1A at the time when they actually get their organ. And so if you look at those who are 1A, which is the blue lines in the top two graphs, in the graph on the right, this is mortality, listed 1A, blue, 1B, red, and 2, which is the kind of gray-brown color at the bottom. Adult congenital patients are the solid lines. Non-adult congenital patients are the hashed lines. You can see that there's a trend towards increased mortality, particularly among those listed 1A. And if you use the combined endpoint of dying or delisting due to clinical worsening, which I argue is a more relevant endpoint because if they don't die on the list but they get delisted due to clinical worsening, that means they die. They just didn't die while you were watching. Then there is actually a statistically significant increase in rate of death or delisting due to clinical worsening among the congenital heart disease population compared to the non-congenital heart disease population. That's depicted in the graph A. Clearly, whoever published this article didn't have my thought process because I just went through the graph backwards from the way that they did it. I don't know why they did it the way they did. So is there any technology that we can use that might help out in this scenario? And it turns out that there is new technology that's not just completely useless, although there seems to be an everything these days, that's been of proven benefit in the non-adult congenital heart disease population for helping patients survive to transplant. And that's mechanical circulatory support, specifically durable mechanical circulatory support in VADs. It's undeniable that in patients without congenital heart disease, it improves survival to transplant. And although it does expose patients to an extra operation and extra blood product, there is some early indication that post-transplant outcomes among patients who have had a VAD upstream of their transplant are at least as good and may even be a little bit better than those who have not been VAD supported. And that's probably because most patients getting transplanted are 1A, which means they're really sick. And if you take a really sick person and stabilize them before you take them to the OR and put a transplant in, they kind of do better after transplant. At least that's the way that I put it together in my mind. The problem is no one is using them in congenital heart disease patients. This is data looking at UNOS, and you can see that while the numbers of patients without congenital heart disease who have been getting ventricular assist devices as a bridge to transplant have been increasing over the past decade, The same is not the case for congenital heart disease patients. They basically have been static at around 3 to 4%. And we can all imagine these are probably like the crash and burn patients where you're like, oh my God, what are we going to do? And somebody says, why don't we try a VAD? And they kind of throw a VAD in. And I don't think that it's a planned, systematic thing. I think it's used kind of as a Hail Mary in certain cases. And unfortunately, it continues to be that way. And the reasons for this are probably multiple, and it's logical. I mean, you're basically using a device for an indication where it's really not designed. I mean, the device was designed in a way that it interacts with a particular anatomy favorably. And the anatomy in congenital heart disease patients really don't match the anatomy for which these devices were designed. Furthermore, we're exposing somebody who's already had multiple sternotomies to an additional sternotomy. You're exposing them to additional blood products when they're already allosensitized. And just no one else is doing it, and you don't want to take on that liability. And so I can understand the mentality behind it. And for that reason, I decided to do an INTERMACS analysis and take a look and see, among the small number of patients who have had a mechanical circulatory support device implanted, how do they do compared to the general population? And do we need to really be so concerned about what the outcomes might be? Is the fear of the unknown, is it justified? So, starting to look at outcomes in terms of common post-MCS complications. Is there a difference between adult patients who got a durable mechanical circulatory device and who had ACHD and those without ACHD? And this, if you look at these are Kaplan-Meier curves, and each of them is for a different complication, going from top to bottom, from left to right. Time to first rehospitalization post-VAD, no difference. Time to first neurologic dysfunction, that's code for stroke in INTERMACS, no difference. Time to first bleeding, no difference. Time to first infection, no difference. Time to first device malfunction, no difference. Time to need to exchange the device or upgrade to BiVAD or add an RVAD, no difference. So, seems like they actually do okay after you get a VAD implant from the outcomes point of view, in terms of medical complications of VAD implant. How do they feel after VAD? They feel great. All of the benefits that patients without congenital heart disease enjoy from mechanical circulatory support, ACHD patients enjoy those same benefits. Looking from, again, top to bottom, from left to right, similar improvements in 6-minute walk distance, which is a measure of exercise capacity. Similar improvements in 5-meter walk time, which is a measure of frailty. Similar improvements in NYHA functional class, as well as in health status as assessed by KCCQ. And similar improvements in quality of life as assessed by the EuroQoL 5D and the visual analog scale. So they feel better. So their complication rate is similar. You make them feel better, but are you actually improving their outcomes? Are you actually decreasing mortality? And what we found is that no. They have a higher rate of mortality after VAD implant than those without congenital heart disease. And that's what we're showing here. But if we dig down deeper and look at the competing outcomes here, there are a couple of things that become apparent. This is non-ACHD patients. This is ACHD patients. The green line is patients that are alive with a device in place. The blue line, patients who are alive and transplanted. The red line is people who have died. So if you look at the probability of having been transplanted at 1 year, this is one major problem, is that patients with congenital heart disease are sitting on the VAD for longer, and the longer you sit on the VAD, the greater the probability you're going to experience an adverse outcome. You can see there's over 10%, nearly 15% difference in probability of being transplanted at 1 year after you've had a VAD implant if you're an ACHD patient. And you can see the number that are still supported on VAD is higher among the ACHD population. And this reflects what we had alluded to earlier. that congenital heart disease patients wait longer for their transplants than non-ACHD patients. And the second thing that we get if we drill down is that most of this kind of increase in mortality is all early on. It's all perioperative. And given that the INTERMACS database has all of 128 patients with congenital heart disease that have had a VAD implanted, I'm going to guess that some of this may be attributable to just the complication of putting a VAD in complicated anatomy, but some of it is just due to the fact that no one's doing a lot of them, and you get better at things that you do frequently. And this was seen with early VAD data as well, that perioperative mortality rates have gone down as people have implanted more VADs, as people become more experienced with the implant and with the technology. And so we did actually, in recognition of that, we did a subsequent analysis where we censored patients for the first 5 months after VAD and looked at outcomes. And you can see that actually, if you get through this perioperative period and convalescing from it, actually outcomes are no different between ACHD and non-ACHD patients who are supported by a durable mechanical circulatory device. So basically what we need is for people to get more accustomed to doing it and to use it more, because otherwise the outcomes are quite favorable. Now, what are some other reasons why these patients may have an increased perioperative mortality? So an anecdote is in order here, I believe. So this is a patient that I saw, I guess, a couple of years ago, who was born with a heart defect that he said, I have transposition of the great vessels. I said, okay, well, that's great. So have you had surgery? Yes, they closed a VSD. I said, okay, so it must be congenitally corrected transposition of the great vessels. He says, no, they told me I have detransposition of the great vessels. Okay, but then you have an arterial switch. No, they just closed a VSD. So I didn't know exactly what was wrong with this guy. I didn't really know what his anatomy looked like. As usual, he had been repaired on the East Coast. I saw him in Texas, and we had no records. He was followed at some small community hospital in Pennsylvania. And so we got an echo. First we got an echo. It came in profound heart failure. First got an echocardiogram, and for all the world, it looked kind of like detransposition, but I couldn't see a baffle. And I couldn't figure out, what was going on with this guy. So we did a cath, and he had high filling pressures and all the things that go along with systolic heart failure. But when I went to look at his coronary arteries, because he had like a little, heart sweat when he came in, which, these patients with heart failure will come in with heart sweat. That's translates into a little troponin leak when you're in with heart failure. Sorry, you're not familiar with my lingo. So I cathed him, and I noticed that the right coronary artery was coming off of the leftward facing cusp. So, which goes along with L transposition of the great vessels, but his ventricles were not twisted that way. And it turns out what this guy had was a crisscross heart with transposed great vessels. So he basically had done his own atrial switch, more or less. He had done his own mustard in utero. And that's the reason why he probably only did. Patients are almost always right. If he says, no, I had a VSD closed and that's it, he was right. That's all that they did for him. And he had actually done remarkably well with the systemic morphologic right ventricle, which was kind of like, it wasn't really on the right. It was kind of like upstairs, and the left ventricle was kind of downstairs in his case. So we couldn't get him out of heart failure. We could not diurese him well. And I said, this is somebody, we need to do a VAD. We've done VADs in patients with a systemic morphologic right ventricle and transposed great vessels are actually among the congenital heart disease population. That's one of the groups where it's been done more often than in other groups. And so I said, well, let's do it in this guy. So I talked with a surgeon. I said, maybe we should get a congenital surgeon involved. And, I know that surgeons are very collaborative under normal circumstances. This guy was not interested in having anybody else in the OR with him telling him what to do. So he went into the OR and he put the VAD in where he thought it looked like there was just the most space for it, which ended up being high in the free wall of the RV. So you can imagine what probably happened as soon as they turned it on and the ventricle was unloaded, was the inflow canyon went right towards the septum. And so this guy was having low flow alarms. He was having suck down all the time because, and they had this they were kind of fighting. They were like, give him fluid, then he'd get fluid overloaded, but then his VAD would flow okay. And then they diurese him, and then his VAD would stop flowing, and it was just a mess. So they actually took him back to the OR, and I said, dude, put it in the apex. Okay, that's where you need it. He's like, no, there's these muscle bundles down there and the moderator band, and you're not a surgeon. You don't know. It's hard to resect all that stuff. I'm like, all right. So they moved it kind of a little further down where it looked like there's a lot of space there. And the same thing happened. It was the same thing. So he took him back and repositioned the inflow cannula again, and it happened again. We were not going to take him back to the operating room. Ended up that we managed to get him through this perioperative period through kind of careful and judicious management of his medications and a little pulmonary vasodilator to try and help facilitate filling of that systemic ventricle. And he only was VAD supported for a couple of months before he was listed for transplant and got successfully transplanted and ended up doing really well. Now, I wouldn't consider this a good outcome of VAD after ACHD, but it could have been had things gone a little bit more smoothly with the operation. But all of this to demonstrate that the anatomy is different and it's complicated. And obviously, we don't have 100 patients with a systemic morphologic right ventricle who have gotten a ventricular assist device implanted, and there's no standardized way to implant these devices. And so, the surgeon can be forgiven for the fact that he just didn't know where the right place to put the inflow cannula in was, because nobody does. I mean, he could refer to all 3 case reports in the literature which have described how the inflow cannula was placed, but I don't know, given the variability of anatomy, and this wasn't the most typical systemic morphologic right ventricle in terms of its location and orientation, I can understand also his point of view. And so that is it's not only just experience, it's the fact that the anatomy is complicated, and so that is going to predispose patients to having these higher perioperative mortality rate. That being said, regardless of anatomy, outcomes in ACHD patients are the same. Now, take this with a grain of salt. You will note that there are, all 17 single ventricle patients who got a ventricular assist device seemed to do as well as all 45 who had a systemic morphologic RV and 63 who had a systemic morphologic left ventricle. But it seems that regardless of anatomy, they have a little bit of perioperative complications, but that there's no prohibitive anatomy, even single ventricle patients. So, you put a VAD in. Your goal with the VAD is to get somebody to transplant in a healthy state. So how does that impact their post-transplant outcomes? And this is data looking at UNOS. This is from David Morales in Cincinnati. And this is looking at ACHD patients who got transplanted without a VAD, which is in green, versus those who had a VAD as a bridge to transplant in red. And you can see that outcomes are no different between the 2 groups. Drilling down a bit further, the top graph shows propensity-matched outcomes for ACHD versus non-ACHD patients, matched for predictors of post-transplant mortality. Again, no difference in mortality between the groups. And even more intriguingly, if you look at B, this is a selected high-risk cohort, so patients with lots and lots of risk factors for bad outcomes post-transplant. There's a non-statistically significant trend towards improved outcomes among patients who were bridged to transplant with a VAD versus those who were not. So post-transplant outcomes, you're not hurting the patient, it seems, by putting a VAD in them upstream of transplant. And in terms of whether or not this can actually improve waiting lists, delisting due to clinical worsening or mortality, this is preliminary data. This is a project I'm working on right now. This is data from the SRTR database. Unfortunately, we are hampered by very small event rates, so it's hard to achieve statistical significance. But among patients who who were delisted or who did die during while listed for transplant, if you look at the CHD patients on the left versus non-CHD patients on the right, the number of days between listing and delisting due to clinical worsening or dying is increased by VAD. You can see it's substantially longer in those who had an LVAD at the time of initial or last listing status 1A or 1B compared to those without an LVAD. This achieves statistical significance in the non-ACHD group. It does not in the CHD group because event rates are so low. But the actual numerical change is fairly similar, which does suggest that ventricular support or durable mechanical ventricular support could potentially help close that gap between ACHD and non-ACHD patients in terms of waiting list mortality. So, what about Fontan patients? And we've talked about earlier when the first two patients that I presented, I love Fontan patients. Everybody in congenital heart disease love Fontan patients. If you look at when we have these national committees and everybody gets to decide what subject they want to focus on, everybody signs up for Fontan. When there's those breakout sessions at national meetings, everybody goes to the Fontan session, and if you're in the TET session, you're there with 3 other guys and the guy who's filming. It's just remarkable. So, can ventricular circulatory support be of benefit in Fontan patients? And this is really kind of the next frontier, because Fontan patients, they go young, and they need transplants, and their peri-transplant outcomes, as we've already seen, is worse. Is there something that we could do to improve that? Now, people have used them in Fontan patients, and these are kind of published case reports from various institutions, and most people had used the heart wear devices before, and I think the first case of the HeartMate 3 implanted in a Fontan patient was done in Cincinnati. It was published just a couple months ago. But no one really knows what it's doing to the circulation or the physiology as a whole. There's no data whatsoever on what happens to Fontan patients physiologically after you implanted that. The only data that we have available is in silico computer modeling. And so what that shows, and I'm going to explain this graph because it's kind of complicated. Fontan patients can fail, for those who are not in the club, in kind of one of 3 general ways. They can develop systolic ventricular dysfunction, diastolic ventricular dysfunction, or elevated pulmonary vascular resistance. Each of those 3 is kind of like end-stage Fontan heart disease. So, divided into those 3 groups, this is from a group from Rome, Italy. They looked at what the physiology would look like in the pathologic state, and then how ventricular assist device, cavopulmonary support, and cavopulmonary support translated into English is RVAD for somebody who doesn't have a right ventricle, and biventricular support, how their physiology would change in each of these circumstances. So we'll omit the majority of these things that are like PA pressures and aortic pressures, but concentrating on the columns to the left, you can see that cardiac output improves with ventricular assist support device, cavopulmonary support, or BiVADs. In terms of the actually color-coded columns, the one furthest to the left is healthy Fontan. The one next to that is failing Fontan, failing for the reason in the title at the top. The third column is ventricular support. Fourth column is cavopulmonary support, and the fifth column is biventricular support. So sorry for the complication level of the graph. But you can appreciate that regardless of what kind of support, you get improvements in cardiac output with ventricular support, with mechanical circulatory support. Obviously, if your problem is increased pulmonary vascular resistance, ventricular support alone does not help much with cardiac output, because that's not the problem. The problem is the ventricle doesn't get filled. But what was intriguing to me is this last column is central venous pressure. And these columns would suggest that central venous pressure goes up with a ventricular assist device, which is, to me, counterintuitive. I mean, if you have normal pulmonary vascular resistance, and the reason why, then your central venous pressure should be essentially dictated by what your ventricular filling pressures are. So why, and we know ventricular assist devices decrease ventricular filling pressure, so why would CVP go up? And I think that in this computer model, what they're doing is they're loading the venous reservoir by improving flow from the ventricle. And they're not accounting for the fact that when you increase cardiac output, your kidneys pee more. And so that venous reservoir actually will be emptied. Anyway, as a result of investigations like this, a lot of the field is focusing on cavopulmonary support. There's a guy named Mark Rodefeld who's developed this device and has got some venture capital money where they're looking at cavopulmonary support and failing Fontan hearts. This is an impeller device that's being developed by a woman named Amy Throckmorton at VCU in Virginia. And he's got lots of publications looking at that. And if you ask David Morales, he's like, just get it all out of there. Just put a total artificial heart in. That's the way to go. And all of these things may well work very well. I would say if somebody has either systolic or diastolic heart failure and you put in a cavopulmonary support device, you're going to just buy yourself pulmonary edema. But I mean, you're going to shift the fluid from one location to the next, but you're not going to actually improve the function of the ventricle. But I could see how these might be beneficial in addition to ventricular support. And I can totally understand David Morales' point of view. But I will posit to you that it makes intuitive sense that ventricular support alone should improve physiology. And we have devices that are so well vetted in this field that we know work well. So what we're doing now is trying to collect all 20 patients in the United States who have had ventricular assist devices implanted in a Fontan palliated single ventricle circulation and see what the physiology is after we implant the device. What does it do? Does it actually load the venous system? Or does, makes intuitive sense to me and as has been reported anecdotally by physicians who have cared for patients who have been in this situation, does it actually improve their physiology and decrease their central venous pressure? And so that's kind of where we are at the forefront of this field. And I think this is really an area ripe for improvement, because if we can offload that venous system and if we can better perfuse the organs in Fontan patients, there's a good chance that we could start moving those dots for Fontan patients post-transplant and their outcomes back towards the middle and towards improvement, because their end organ function after transplant will be better. Now, I know what you're all asking. You probably don't even remember at this point, but I did start the this presentation with the elephant leg guy. So what happened to him? Unfortunately, his story is not a happy one. So he came back into the hospital, this time for the first time without heart failure, but unfortunately with a pneumonia. It was due to hypogammaglobulinemia, probably as a result of his protein-losing enteropathy. We treated his pneumonia, and we gave him, repleted his gamma globulin. He stabilized, and I tried to get him listed for transplant. They said, no, he's too sick to be listed for transplant. I said, this is a 29-year-old guy. Let's give him a chance. Why don't we do a VAD? Let's try a VAD. I know it's not been done before, but let's do it. What's the downside? This guy has got 100% mortality if we do nothing. And I could not convince the surgeons to put a VAD in him. And so he ended up getting sent home on hospice and dying. And, that really, for me, it brings home that we need to be using these devices in patients a little bit more than we are. And we need to be using them before they get to that point. There's a good potential that they can help out. It seems like outcomes are not dissimilar to those in the population of patients without congenital heart disease. And if you wait too long, it becomes a self-fulfilling prophecy. If somebody's really sick, you take them to the OR, they're going to die no matter what you do. So I'll leave you with a few items to ponder. First, ACHD population is growing and they're dying of heart failure. Transplantation is a great option and they do well with transplant, but they have more perioperative complications. They frequently go into transplant sicker, and getting them to transplant is harder. They die on the waiting list. And more organs are just not being made available. There's like seatbelt laws in most states now. People just, if anything, the number of organs available is going to decline. It's certainly not going to go up. And so this is an area where ventricular assist devices may be a benefit. And with that, I will remind you that Halloween is just around the corner, and that your children, like mine, are probably very excited about the overflow of candy that they're about to consume. And I will open up for questions.
That was really great, Ari. Thank you for that wonderful talk. So one of the really interesting things that actually Tom and I were sort of talking about as we were looking at those graphs and trying to understand a little bit better about where the mortality happens in ACHD patients that are getting VAD is it seems like a lot of that mortality happens, there's a little bit of an inflection point after maybe 6 to 9 months of being on a VAD. Is that reflective of what you think may be happening, or is that just sort of me sitting pretty far away from the screen?
So I'm actually not 100% sure what that's from. I think there's a lot of upfront perioperative mortality. I didn't know, let me see, I have to go back to see what the inflection point of 6 to 9 months that you're talking about. So you're talking about this inflection point here?
Yeah.
I don't know what that's from, and I didn't actually, when we did the analysis of this, the best fit curves that we came up with were two, one for months 1 to 5 and one for thereafter. And so with that inflection point was not noted on the when we were doing best fit curves on analysis. Now, this may be real. It may not be real. Keep in mind these are all 128 patients, and so it takes one extra guy to die to have an inflection point in this small number of patients. So that may or may not be real. If it is real, I could come up with some hypotheses. It may be that there are patients with out congenital heart disease when they have a VAD complication, when their VAD starts dysfunctioning, or when they need thrombosis or something, you have a decision point. You can either exchange the VAD or you can list them 1A for transplant. And at that point, I think that maybe more of the general heart disease population, they just do transplant, and more of the congenital heart disease population, they maybe do another VAD, and that may be a part of the reason for an inflection point at 9 months, if there actually is one.
Thanks very much, Ari. That was a great talk, both in terms of content and style. Really terrific. A comment and a question.
Sure.
Unlike tailored medical therapy for heart failure, the VADs that we have now are sort of off the rack, and they fit the traditional dilated cardiomyopathy patient pretty well. But we also know they don't work as well with patients with restrictive heart disease, and certainly none of these congenital patients are off the rack kind of wearers of durable devices. So I think as the devices get smaller and better, maybe they'll fit these patients better. My question has to do with, as you pointed out, many of these patients have other end organ dysfunction, and the one that has really been perplexing to us is liver disease. Many of these, certainly single ventricle patients, have congestive hepatopathy, and we spend a fair amount of time talking about how much is too much. So can you give us the benefit of your experience of how you sort of decide about whether somebody with liver disease with single ventricle physiology can get a heart transplant or get a heart and liver transplant and so forth?
I can't share my experience because I think I have an N of 1 of a Fontan patient who I sent for transplant. The group that probably is most aggressive about doing heart-liver transplants is at CHOP, and they seem to think that almost every Fontan patient should just be listed for heart-liver unless there's some ideal scenario where they don't need to be, their liver just looks awesome. And then there are people who are at the other end of the spectrum that say, liver comes back, congestive hepatopathy is largely reversible, and all you need to do is remove the provoking stimulus. And I don't actually know the answer. What I do know is that in the analyses that have been done of heart-liver transplants, outcome in combined transplant, and there are a few, outcomes in congenital heart disease patients are really no different than in the general population or non-ACHD population. But the thresholds at which I would say you need to actually list for both heart liver versus just liver alone, I can't say. And I think there are a lot of reasons for this, and I think one of the primary ones is we don't really know how to define Fontana-associated liver disease very well yet. They don't really get a large transhepatic gradient, even if they do have substantial cirrhosis, because just their central venous pressure is so high. They don't get a good. The transhepatic wedge is never particularly high, and liver stiffness is always elevated just because it's congested. And so the stiffness ratings may or may not correlate with cirrhosis. And then even if they have some cirrhosis, if they have no evidence of synthetic dysfunction, if you remove the provoking stimulus, it may come back. And so, I'm kind of talking around, and the reason why I'm talking around is because I really don't know. And I think that's one of the areas of active research in the field right now is to figure out what thresholds should be for replacing the liver at the same time as the heart when somebody's listed for transplant.
Fascinating talk. Thank you for that. Two questions. One is, I think as heart failure physicians, we have a difficult time really understanding how sick these patients are because they don't fall into the classic Intermax category where, if you're looking at implanting an LVAD, where we know that at least from roadmap that anybody from 4 through 7 really don't benefit right away, and probably should be implanting VAD in 2 to 3. And by the time these patients get to Intermax 2 or 3, it's probably too late. So, how do we truly, assess because they're all young. So, using MVO2s, or even if you want to look at, any of the functional parameters, it becomes really difficult because they're all very young and they probably perform fairly well. Like you're saying, all your patients were working till the day before they decompensated. So, it is difficult to make a case to them that they need to undergo an elective LVAD surgery, which will be potentially life-changing for them. And also, as physicians, it's really difficult to predict who's going to not do well in the next 30 days or 6 months.
So you're absolutely right on most of what you said, and on one thing I take an issue with. So I disagree with the interpretation of the roadmap data, and I've kind of taken a look at that. But I understand that is definitely what the top line data was on roadmap. I think that actually roadmap, they kind of were pooling different groups of patients together maybe, and that there's a certain group who probably did better than the other group. But what you're hitting on is actually a big problem for congenital heart disease writ large, in general. We don't even know when to refer for transplant, and it's for that exact reason. The 20-year-old has so much reserve, they're doing fine until they're really not doing fine, and they fall off a cliff. And it's very difficult to know when that threshold has been passed, not just for implantation of a VAD, but for referral for transplant at all. And, the VO2 max guidelines are basically not applicable because, my Fontana patients who are doing great have a VO2 max that's would refer them for transplant if they had a normal heart. And so we don't really have a good way of defining who should and who should not be referred for transplant. Now, I can tell you there's an ongoing study specifically in Fontana patients called Foster. I don't know if you've heard about this, but where they're looking to see patients who were referred for transplant, those who did versus those who did not get transplanted, and see what their outcomes were, and try and identify predictors of adverse outcomes and try and identify those clinical thresholds for transplantation. And those in the Fontana population could be extrapolated to VAD implant. In the non-Fontana population, your guess is as good as mine. I mean, I don't know what thresholds we should be using. I think that in general, from the practical standpoint, when somebody starts getting admitted more than 3 times in a 6-month period, we're like, and it's for heart failure, they probably need to be referred for transplant. And you're right, if somebody's, ambulatory doing well and feeling fine at home, then yes, it's very hard to tell them that they need to have a VAD put in. But I don't think that anybody puts VADs in those patients who don't have congenital heart disease either. I think
Right.
VADs
No,
are.
no, no. I know, I agree, but what I'm saying is, like you were saying, it's very difficult to know their reserves. So,
Sure.
if you want to make a case to do LVADs in kind of feeling fine, but actually much sicker patients, it's always difficult to, convince.
Right, and I think that in this population, like you said, you're not going to get somebody who's going to come in and say, I just feel terrible and I'm not able to do anything like you do in maybe the general acquired heart disease population. And it's going to be more when they get hospitalized and it seems like you can't keep them out of the hospital, that's going to end up being the threshold, at least for right now.
All right. Well, so we'll go ahead and leave the questions open for if you guys want to come up and talk to Dr. Cedars. Thank you guys very much. Thank you, Dr. Cedars.
Thank you. Yeah, you're welcome to.
Yeah, that was awesome. Thanks very much. Yeah.
Oh, yeah, yeah.